Yeah, yeah. There's also a story where Johnson, I think, used this surprise press conference technique a couple times. When Senator Harry Byrd comes to visit him, and Byrd was chairman of the Finance Committee, and he also was not really, he was very much a fiscal hawk. He did not want to spend government money, and he was not thrilled about Medicare. And they had a private meeting in the Oval Office, and then he takes him into the press room for a press conference where he puts him on the spot without telling him this is going to happen at all. It's like, well, I guess I have to agree.
Right. Johnson was a great manipulator, and I don't know. I guess we can sort of, by implication, contrast him with President Obama, who does not like to schmooze in politics. He doesn't like to hang out. At least that's my impression. Whereas Johnson was always bringing these guys in the office and sort of lean in on them physically and say, "You're going to help me out," put his arm around their shoulder. And I think that sort of style was part of Johnson's effectiveness, but I don't think President Obama likes to do that.
Well, I think the difference is it helps when you have huge majorities.
That's true.
Johnson was able to do that in his first, that first couple years. And the interesting thing is, after, and this is, Pam mentioned this book that's coming, one of the Medicare books that's coming out in June that we're having a NASI event around. And Julian Zeitzer is a writer, a professor from Princeton who's one of the contributing editors. And he writes about this, about how after 66, when the Republicans were very successful in the midterms, Johnson was not nearly able to, all his big legislation was pre-66. And, he wasn't able to do that. So, it's great when you can you can do that when you have big majorities. And I think.
Okay, point taken. In other words, it's more effective to schmooze when you also.
When you have the power, it's easy to be schmoozy about it. So, you mentioned the unions, which were obviously they were a bigger force politically back then. Why were the unions so in favor of this? What was in it for them?
Well, they thought unions were starting to get good contracts, especially with the automakers. They had very good health benefits. It was becoming an important thing. And part of it was that you had a health benefits for the workers, but then when you retired, you also had it. So if you then passed something like Medicare, Medicare would take care of the retirees, so there would be less money spent by the company on retired workers, since Medicare taking them. Therefore, there's more money left to increase the benefits for the people under 65, to increase their health benefits. So the unions thought, it's a great deal. We have contracts, we cover you up to 65, then you retire, you go on Medicare. So we're putting more money into the under 65, and the government is taking care of those over 65.
Right. And I think for people who aren't familiar with it, that position was a change for unions. Originally, back in I'd say maybe it was the Truman days, unions actually were not supportive of national health insurance. They would rather negotiate this with their employer because they were they felt more secure about that. That came from their bargaining power, and they weren't dependent on politicians and the majorities changing in Washington. So we get to July of 65, and it passes. Can you talk a little bit about sort of the difficulty of implementing this program?
Well, they had two things. They had a number of things. One is basically getting the word out to people, getting people to sign up. Because remember, hospital is automatic, B is voluntary. So you have to get millions of people to sign up for Part B. And they had mass mailings, they had distributions. You go to the post office and get the form. And considering that computers were pretty primitive in those days, they did a pretty good job. Because out of the 20 million people who were eligible, I think 18 or 19 million signed up for Part B for the doctor benefit. So they worked on that. Again, Bob Ball, who was running Social Security, did a very efficient job of that. So by '66, they were ready to roll it out.
Right. I read this interview with Bob Ball. He talked about one thing is they were glad that the bill was signed in July because that meant the implementation was during the summer, and it was going to be sort of a less busy season. And I think they also made this was also a lucky calendar thing. The implementation date was on the weekend. And so they also sort of anticipated less business. But they were really scared. Besides the segregation issue, they had helicopters ready to transport people to hospitals and stuff if there was a rush of people coming in to get health care all, on the first day, and that hospitals in certain areas would be overwhelmed.
Right, they didn't know. They didn't know because suddenly there's this new thing. You're 65, and you can now be covered by this regardless of your health, whatever. So they thought there might be, as you said, millions of people who were rushing to the doctor's office, and the doctors would have to send them all to the hospital, and how would they ever get there? But it worked out. Apparently, people were not as sick as the planners had feared.
Yeah. So that was back in '65. Medicare has evolved a lot since then. Can you talk a little bit about how Medicare has changed and maybe the interaction with the private plans?
Mm-hmm. Well, at the beginning there was traditional Medicare, which is, as I described, A, B, and C, and then, let's see, when did Medicare Advantage start?
Medicare Advantage started in, I want to say I'm forgetting the date. It started originally in a very limited basis for HMOs in, I think it was 89.
Okay.
And then it came in a bigger way in one of the early 90s Medicare bills.
Yeah. So Medicare Advantage essentially are standalone plans. Basically, you get all your care through them, and you stay within their network of doctors and hospitals. Now, remember that Medicare was just supposed to be the first step, and the people who worked on it thought we'll get national health care in 2 or 3 years. Didn't happen. Things continued, and basically the system was the same. And then, we get to where we're having growth in the plan, and then drugs became more and more a cost factor, and people were finding it hard to afford drugs. So the next big thing was the Part D, the drug benefit, which was done under President Bush. Let's see, was it 10 years in 2003?
2003 and implemented in 2006.
Right, President George W. Bush. And I remember having a conversation with the people at AARP then. Basically, here was the administration, Republican administration, saying we're going to add to Medicare, we're going to cover drugs. So if we do that, older people will be very happy and they'll all vote for us. At the same time, so AARP is deciding, what do we want to do? Do we want to back it? And the Democrats were saying, don't do that. When we get back into power, we will give you a drug benefit. They had to make a decision. And I remember talking to the AARP people who had often been lobbied effectively with the Democrats. And what happened was they said, okay, the Republican administration is promising us $200 billion in drug coverage. The Democrats are saying if we get back into power, we'll give you even more money. And they said, we don't know when the Democrats are going to get back into power, so we better go with it. So AARP backed the Republican plan, which led to Part D, the drug benefit. So that was a big boost, but part of the deal that was made was that the government could not regulate the price of drugs. Even though the government was going to spend this huge amount of money to pay for drugs, they couldn't tell the manufacturers what to charge. Politically, that was about the only way that they could get it through. So the VA can negotiate. Medicaid can negotiate for rebates. But Medicare, the biggest of all and the biggest buyer of drugs, cannot negotiate. And that is one of the themes that continues.
Right. It's funny. I remember from one of your early columns when people were advocating for Medicare, and they talked about the health care costs seniors were facing, and they talked about the fact that a day in a hospital cost $40, and this was a huge problem.
Right.
And and now, and yes, come the 21st century, and really pharmaceutical costs are driving a lot of things, and that's the big concern. It's funny because I was actually involved. I was working for a beneficiary organization, and we were involved in lobbying on this when Part D was being talked about. And the other issue, besides the money, of course, was Part D was created by having private plans offer coverage. And that was the big thing. The administration wanted private plans. That's the only way they would do it. And the Democrats said, well, we'll do Part D like A and B. We'll just have traditional coverage that the government will offer. You don't have to we won't do private plans. And that was a hard decision ARP made. And when they made the decision, it wasn't just ARP, actually. It was also, the big thing was Senator Hatch was pushing this for the administration in the Senate. A drug bill had passed the House, and it was in the Senate, and Hatch was pushing it for the Republicans. And Kennedy and Hatch cut a deal. And that was the big thing. Kennedy crossed the aisle, did this deal with Hatch, and ARP supported it, and then it all kind of flowed from there. And a lot of sort of consumer groups really criticized ARP for this. And it seemed like they were sort of selling out, And I'm not saying they had a crystal ball, but this was 2003, and by 2008, 9, 10, there was no money for a drug bill if they had tried to pass a drug bill. That window, that fiscal window of opportunity closed. So whether they were lucky or right, that was a really fortuitous decision, I think, by ARP.
Yeah, I think it turns out to have been a very good piece of strategy. And then sort of leaping ahead, then Bill Clinton becomes president, and we're going to have another run at national health care. We're going to figure out a way to do it because we now have a liberal Democratic president, a liberal Democratic Congress. So Bill Clinton decides to do it. And then, interestingly, he appoints Donna Shalala to be head of HHS, who is really smart and really tough and political operative. So everyone figures, I remember I was covering this, well, Donna Shalala is going to be in charge of this. No, the White House says Hillary Clinton, the First Lady, is going to be in charge of pushing for national health care. And I think that was, politically, it was a problem, at least it looks that way to me in retrospect, because had Donna Shalala been running it, she would go to the hearings, they would have the public and private negotiations, and she would say this, and they would say, oh, it's terrible, we can't agree with that. They would fight back and forth. The problem was when you have the First Lady doing it, if you're a member of Congress, it's very hard to negotiate with the First Lady because she has a different position. She's not a politician, so it's hard to say to the First Lady, you just said a really stupid thing. We're not going to do that. Or Clause C is much better. You could say that to Donna Shalala. So I think from the beginning, it was difficult for them. The other mistake they made is they brought in lots of really smart people. They brought in several hundred people from the academic world, from insurance companies, and they sat in Washington and they drew up these plans, and they didn't talk to members of Congress. I remember Pete Stark, who was the Democratic health guy in the committee. I remember him telling this story, is that he wanted to go to some meeting in the White House, and there were a bunch of people sitting around and they told him, you can't come in. So there were all these 30-year-old smart people with PhDs figuring out the health system, but they didn't let Pete Stark in, so they never even got to a vote. Is that?
Yeah, I mean, and Pete Stark controlled the health subcommittee of Ways and Means, so that was like not a smart thing to do. I mean, the other problem is, I think you're right about the First Lady issue, and it was even more on if you combine those two things.
Yeah.
There's a bunch of NACI members who were involved in that, and I've heard them tell me stories about, it's one thing to go to if you work for the president, to go to the chief of staff or to go to whoever your boss is, or even to go to the president and say, this advisor is wrong. I really don't think our bill should include this provision. It's another thing to go and say, your wife is wrong on this.
Yeah, your wife had a dumb
idea. So actually the internal administration negotiations were even more screwed up, I think, because of that personal relationship.
And one of the things they learned, sort of jumping forward, one of the things that President Obama and his staff learned is they didn't bring in all these outside experts. They basically did negotiation with people in Congress. So it was a much more I think, much more skillful handling of it.
Right. And that reminds me of some of the things you wrote about with Medicare, right, where it was just Wilbur Cohen for the administration sitting in a Ways and Means hearings, negotiating with Congress as they sort of, crafted the bill.
Mm-hmm.
So Medicare has had a big impact on the healthcare system. Sometimes it's been very innovative. Sometimes it's had to be catch-up to what's going on in the private sector. Can you talk a little bit about that?
Yeah, basically, it sort of sets the pattern. Once Medicare approves a procedure, I think heart bypass was approved in 65 or 66. Then it becomes universal. Medicare approves it, and all other insurers approve it. And the same with drugs. So it's sort of the pace setter. And the Medicare pay scale is often adopted by other payers like insurers. So that it has had, basically, it's the core of the system in terms of innovation.
Right. I think that's really true on payment systems. So I'm getting the signal that this is a good time to turn for questions and answers from the audience. Why don't we take questions?
Bob, how soon after Medicare was enacted did Medigap policies emerge? Was the insurance industry ready from day one to fill the gaps in Medicare?
That's a great question.
Yeah.
I don't know but it was a couple of years. It was not right away. So, because back then, Medicare was crafted to address this issue of hospital costs. And the out-of-pocket cost wasn't clearly such a problem for consumers. So I don't know the year Medigap started, but I think it must have been not until the 70s or 80s even. Probably not till the 70s. I mean, it's just the out-of-pocket costs were not such a huge problem.
Right, and then they jumped up and it was necessary. So this is the insurance industry steps in with a very helpful product.
Yeah. That's a good question. Other questions? All right. Well, okay. Go ahead, Anna.
My impression is that a mistake that was made back then, and I think both with the private insurance and also with Medicare, is that we didn't really understand that the patterns of payment drive the patterns of care. Do you have any comments? Is that a good observation? And is there anything we can learn from that?
Yeah. Do you want to start? Or
Go ahead.
Okay. So, I think part of it was the politics. I think if you look at the beginning of the Medicare bill, it basically says we're not going to get in the way of the practice of medicine. We're not going to, and it's very clear that part of the political reassurance that had to be given to the medical community was we're not going to set rates, we're not going to tell you how to practice medicine. And Medicare said we'll pay the reasonable and customary costs of what you charge on an outpatient basis, and we'll reimburse you. It'll be cost plus for inpatient. And that was a huge problem. It was basically handing the keys to the Treasury over to the healthcare system. But it was in part to address a political concern. And then once the magnitude of that problem was realized, then you had the prospective payment system being developed and the RVRVS system for creating a way to value physicians' time and physicians' procedures. But the private sector was also no better at it than either. I mean, these were developed in the public sector and then adopted by the private sector. So I think this was a system, an industry-wide problem, I should say.
It's right. I think the political thing underlies it the most. Again, remember they were worried about the doctors striking. Then they knew, okay, they're not going to strike, but maybe they'll balk at the system. So they said the way we're going to make the doctors happy is to say they can charge customary and reasonable payments, essentially saying to the doctors, it's the honor system. Whatever you say you charge now is what you can charge. So the doctors had the fees, and then the more you do, the more you get. And ironically, under President Reagan, who is noted for his conservatism, we set up sort of a Soviet-style system. We have this list of thousands of codes for you go to the hospital or you go to the doctor, and each thing that a doctor does has a particular code designation and a particular price. So that's the system we've operated under. And, you know, the more you do, the more you get. So now we're struggling to go to a new system, which you heard about before, which is you sort of get a lump sum for a kind of treatment, and hopefully you can control the cost that way.
Okay. Do we have time for one last question, or are we?
Let's do one more question if we have one.
Any more questions? Well, I'll give you a question, Bob, which is, so Medicare is 50, and what do you think, what's the biggest impact Medicare's had on the country?
I think that Medicare, along with Social Security, means millions of older people have a secure life. They have a secure economic and a secure life physically. A, you don't have to go live with your kids. B, you don't have to get a check from your kids to pay the doctor. And C, you can be independent. Remember, before we had Medicare, there were county old age homes. If you did not have someone who would take care of you, you went to a home. And that was you went to a county home. It's a very bad place to be. So Medicare has given people the chance to live independent, healthy lives.
Yeah. I mean, I think the only thing I'd add is people don't, I think, often appreciate the impact Medicare has had on the younger generation because the older generation is secure, right? Young families can save for their kids' education. They can save to buy houses. They can save for their own family needs, and they don't need to worry about how much are they going to be on the hook to have to save for their parents' medical needs. So, all right.
And now it's time for that annoying guy with the shepherd's hook to take off these most interesting participants from the stage. Please join me in thanking Bob and Lee for this conversation. So now we know the new term for the home is long-term care facility, right? Okay, see, we learn so many things in any given day.